Hi, everyone. We'll be starting in just a couple minutes. Hello, everyone. Good afternoon. I'm Dave Wilkin, Chief Operating Officer of the Occupational Health Clinics for Ontario Workers. Welcome to our webinar today on McIntyre Powder mining and health effects. So at this point, everybody participating in the webinar is muted. You can send questions in using the chat function on the presentation at the end. We've left some time aside to deal with that. As you know, OCCU's been looking at the possible health effects of McIntyre powder itself with a large group of, at this point, over 500 miners living and deceased that we have files on at the current time. And in those cases, we're also looking at any health effects arising from the mining environment more generally. Today we have two presentations. The first is from Andrew Zarnke, who's an occupational health coordinator with OCCU and also a PhD candidate at Laurentian University in the biomedical sciences program. And he's been doing research on the physical and chemical properties of McIntyre powder and the health effects of particles of that size and composition. And then second, we'll hear from Dr. Christine Oliver, who is president of Occupational Health Initiatives Incorporated, an adjunct professor in the Occupational and Environmental Health Division of the Dalla Lana School of Public Health at the University of Toronto, and a consultant to the Occupational Health Clinics for Ontario Workers. And she'll be talking about occupational lung disease and mining more generally. So we will next week send out PDFs of the slides from today's presentation to all the participants, as well as links to some of the associated papers that are going to be mentioned, including a number that we've done on mining health effects. And then in 2 or 3 more weeks, we will send out another link notifying you of additional papers that will be going up soon, including 2 that do archaeologies of the WSIB's dusty gold mining policy on lung cancer and the policy on uranium mining and lung cancer. And examining their basis in the science and how the science has changed over the years. So at this point, I will throw it over to Andrew for his presentation on McIntyre powder.
Hello, everyone. Thanks, Dave, for that introduction. So first, I'm just going to start with a bit of an introduction on what McIntyre powder is for people that don't already know. I'll talk a bit about our preliminary work we've done as part of my graduate studies on the characterization of the McIntyre powder itself. I'll go into some physiological responses to inhaled fine and ultrafine particles, how those are implicated in cardiovascular disease, and then also some potential ways McIntyre powder can contribute to the development of disease. So first of all, McIntyre powder is a finely ground aluminum powder. It was used to help prevent the development of silicosis from the inhalation of crystalline silica. So back in the early days of mining, specifically in gold and uranium mine ores that had very high silica content, and when ventilation wasn't as advanced as it is now, we had very high exposures to silica dust, and this was causing a very high prevalence of pulmonary fibrosis or silicosis. So this was developed in response to that occurrence, and they came up with this finely ground aluminum that was meant to prevent the development of silicosis. So it was used in many places around the world. It was used in a majority of the gold mines and uranium mines in Ontario between 1943 and 1979. It was used in gold mines in Western Australia. It was used in the Congo, Belgium, and in a lot of the ceramics industries as well. So in Ontario alone, there was estimated to be approximately 27,500 miners that were exposed. And in Ontario mines specifically, this was a mandatory exposure that you had to have before you went underground for your shift. So this is an image here of the McIntyre mine where they developed and tested the dispersal of McIntyre powder initially. And they came up with the recommended dose of 1 gram per 1,000 cubic feet of locker room air for 10 minutes. So the time was generally just how long it took miners to get ready for their shift. And the 1 gram per 1,000 cubic feet was really for ease of implementation. So you can see the can there was a 10-gram can. So at different mine sites, you could basically calculate how many cans you needed to disperse before each shift by just dividing by 1,000 cubic feet based on your locker room. So in this mine, the McIntyre mine in Timmins, it was approximately 80,000 cubic feet. So they would disperse 8 cans before each shift. And the way it would work is in each corner, you would have a compressed air line like you see in the image, and you would disperse 1 can at a time. The can contents would take about 10 seconds to be expelled, and then they would hold the air line open for about a minute to help with the mixture of the particles in the space, and then you would go to the next corner. So in that example, you would go around to each corner twice, and you would disperse 8 full cans. So you can see how that would take at least 10 minutes to happen, and then you would be then meant to sit there for 10 minutes in that environment to inhale the appropriate amount of aluminum dust. So when I started my work with McIntyre powder, I was working in the lab of Douglas Borum at the Northern Ontario School of Medicine. And the focus of my research was mainly looking at the biological effects of low doses of radiation, including radon gas. And when we were introduced to what McIntyre powder was, we had a lot of really interesting research questions that we wanted to answer. And namely was how McIntyre powder could have interacted with the radiation exposure and if there was a possible synergistic relationship. So before we could start to draw any meaningful conclusions from any experiments we were going to conduct in the lab, we need to know exactly what McIntyre powder was. So we initially started out doing a physical and chemical characterization of McIntyre powder. And the first thing we did was we did some elemental analysis of it. We did X-ray fluorescence, which is a bulk analysis, and ICP-MS and ICP-OES, which is more trace elements. And we were able to detect upwards of 20 different contaminants that were either as particles or dissolved in the aluminum material that was used to create McIntyre powder. And we also looked at the mineralogical composition. And the main finding there was that although it said on the canister that it was aluminum oxide, we actually detected mostly aluminum hydroxide. The main thing that I'm going to talk about today, though, is the particle size analysis that we conducted. And we conducted dynamic light scattering, atomic force microscopy, which you can see an example of an image from that analysis on the right, and transmission electron microscopy. So the image, the atomic force microscopy image, you can see there the scale bar at the bottom is 1.5 microns. And this is an image of some of the smallest particles we were able to image a McIntyre powder, and they were as small as 5 nanometers in size. This technology is very powerful. You can actually get images of DNA molecules and ribosomes translating proteins, which is really cool for me as a biologist, but also just an example of how powerful this imaging is. So just to put that into perspective, this is a bit of a biological size scale to kind of show you from on the right, a full body, human body, all the way down to a single atom. And you can see at the bottom where the McIntyre powder particle size range fits in there. And you can see the lower end of that is very comparable to a single lipid molecule in the cell membrane of a single one of our cells. And one of the things that comes up when we look at the current research is that how easily particles of this size can be translocated from the source of exposure to other parts of the body and other organs inside the body, and also into subcellular compartments within a single cell as well. And when we're talking about McIntyre powder, we're talking about inside the lung. So the main area of entry would be inhalation. And the first culprit is the alveolar macrophages. And because of this particle size, it's able to penetrate down into the lowest part of the respiratory tract, which is the alveolus. And that's where the gas exchange occurs. So to put that into perspective as well, the particle deposition in the lung is very size dependent. And we see in the literature and in occupational hygiene many different definitions. Just to kind of lay those out, so an inhalable fraction of particles would be particles below 10 microns or 10 micrometers. And they can generally have a higher probability of being deposited in the upper respiratory tract, in the nasopharyngeal region, or in the upper respiratory part of the lung. Respirable fraction has a higher probability of reaching the lower part of the lung and into the gas exchange region. And that's generally thought of to be particles below 4 microns. And an emerging topic in the literature is looking at even smaller fractions, which are PM2.5, meaning particulate matter below 2.5 microns, or also known as fine particulates. And that's, of course, below 2.5 microns. And then now with the emerging nanotechnologies, this is becoming a very recent topic of concern for exposures, and also implicated with McIntyre powder because of what we now know about the particle sizes, ultrafines and nanoparticulates, which are defined as particles below 100 nanometers. So if we just look at the recommended dose of McIntyre powder and we convert that to a unit that we're more familiar with, which is milligrams per meter cubed, we just do a straight conversion of 1 gram to milligrams and then 1,000 cubic feet to cubic meters, we get a dose of 35.3 milligrams per meter cubed for 10 minutes. All of our TLVs are threshold limit values that we compare exposures to try and understand whether there's going to be adverse health effects. They're all time-weighted averages over an 8-hour workday. So if we do that with this exposure, we get 0.74 milligrams per meter cubed, time-weighted over an 8-hour workday. Within the Occupational Health and Safety Act, we have different limits that we can compare this to. And when we don't have a short-term exposure limit, which is what we would probably consider McIntyre powder, considering it's only 10 minutes, we would want to compare it to a STEL, or a short-term exposure limit. But there isn't one for aluminum and compounds, which only has a TWA limit of 1 milligram per meter cubed for a respirable fraction. We have what's called an excursion limit, which is outlined as 3 times the TWA for any 30-minute period, or 5 times at any time the TWA. So if we look at that in terms of McIntyre powder, this exposure would be 7 times the current excursion criteria. So when we consider this, there's a huge discrepancy between the dose rate of a low dose of dust, or a low concentration of dust, over a longer period of time, and a very high concentration of dust over a short period of time. And the issue that arises from is the fact that the lungs can only clear particles at a certain rate. And if you assault the lungs with a really high dose of dust, it can hinder the clearance mechanisms. And now what we know about McIntyre being such a small particle size, we know that a very high proportion of those particles are penetrating into the lower part of the lung. And in this lower part of the lung, we have very limited clearance mechanisms. They're unciliated epithelium that's very thin and very closely related to the lymphatics and circulatory system. And the only source of clearance is these alveolar macrophages. And their job is to physically engulf foreign particles and then through chemotaxis move up into the upper respiratory tract where there's more efficient clearance mechanisms. In the upper respiratory tract, we have a ciliated epithelium that has a mucous membrane that works as kind of a conveyor system to help expel foreign particles up and out of the lung where they can either be coughed up or ingested. So the big issue here with lung overload, when you have a very high dose of very small particles, you overload this clearance mechanism very easily. And with smaller particles, the literature has shown that we see this happening at lower doses. And we also see a very higher rate of translocation of smaller particles into the lymphatics and the circulatory system and to other parts of the body. So to shift gears a little bit and talk a bit about potential health effects, now that we understand a little bit more about the physiological responses and the physical characteristics of McIntyre, where does this fit into the grand scheme of the literature that's out there? And PM 2.5 is becoming, or particulate matter 2.5, below 2.5 microns, is a very emerging topic in the literature and surrounding air pollution and environmental monitoring. And one of the major things that's been identified as being a health effect from exposure to PM 2.5 is cardiovascular disease. And according to the World Health Organization, 31% of the worldwide mortality is attributable to cardiovascular disease. We all know very well-known risk factors of cardiovascular disease, like smoking and unhealthy diets and lack of physical activity. These are, in the most part, under our control and can be corrected through healthy living. But one of the things that is often overlooked is environmental factors. In 2018, the World Health Organization reported that estimates of 7 million premature deaths per year caused by exposure to PM 2.5 or fine particulates. A very recent study in 2019 by Lelyveld et al. Estimated that in 2015, there were 8.79 million deaths worldwide attributable to air pollution, with the strongest associations attributable to PM 2.5 exposure. So if we put this into perspective, the World Health Organization estimates that there's excess death rates from tobacco smoking of 7.2 million per year. So if we compare that to what the estimates are for PM 2.5, we could say that PM 2.5 is a higher risk than for cardiovascular disease than smoking is. So just to go through a bit of a summary of what we've identified as potential how McIntyre powder can contribute to the development of disease. So it should be considered 100% PM 2.5 and under the ACGIH definitions entirely respirable. It's been shown that PM 2.5 poses the greatest health risk for cardiovascular and pulmonary disease. Evidence suggests that there's a dose-response relationship between PM 2.5 and cardiac and pulmonary disease. The smallest particle size and high dose rate of McIntyre powder favors conditions for lung overload, and these conditions provide an opportunity for McIntyre powder particles to translocate from the lung into the lymphatics and the circulatory system. So in the literature associated to cardiovascular disease, we see excess relative risk of cardiovascular disease from increments of 10 micrograms per meter cubed of PM 2.5. So if we put McIntyre powder into that category and we time weight the exposure over 24 hours, we would see that McIntyre powder exposures are 24 times higher than the standard increment increase in PM2.5 used in cardiovascular epidemiological studies. The association between PM2.5 exposure and cardiovascular disease morbidity and mortality in the epidemiological literature suggests that PM2.5 exposed minors are at very high risk for developing cardiovascular disease. There's also been a very strong association found between PM2.5 exposure and cerebral vascular disease, which also implicates McIntyre powder into neurological health outcomes, including ischemic stroke and cognitive dysfunction. Inhibited lung clearance mechanisms would likely enhance the effects of subsequent dust exposures, radon, silica, and diesel exhaust exposures experienced in the mine. And that was one of the first things that right away, knowing about lung overload, is just the sequence of events. The fact that miners were exposed to this extremely high concentration of dust directly before they went underground to work in the mine during that time period when ventilation systems weren't adequate and dust levels were so much higher than they are today. Basically, McIntyre powder, if anything, would just hinder and enhance any effects from these subsequent dust and radiological exposures. And there's new research coming out all the time, so I just wanted to point out this study that was recently published in the Journal of Neurology in November, showing a strong association between particulate matter, specifically PM2.5, and episodic memory decline mediated by early neuroanatomic biomarkers in Alzheimer's disease. Thank you very much, and I'll pass over the mic to Christine Oliver, and there'll be an opportunity at the end to ask questions.
Thanks, Andrew. What? Thanks, Andrew. I'm very happy to be here with you today to talk about occupational exposures in mining and health. Trying to get myself organized here. Coming to talk to physicians in Northern Ontario about health hazards in mining is a little bit like bringing proverbial holes to Newcastle, and I recognize that. Nevertheless, I am happy to come to Northern Ontario and talk about health hazards in mining. I'd like to give a little bit of background about my own experiences in medicine. In addition to what Dave said, I do come from a clinical background. I had a clinical practice in internal medicine and also in occupational and environmental medicine in Boston. I have done research in the area of occupational and environmental medicine and taught in this area. In addition, in the early 1990s, I was chief medical consultant to the commissioner of the Department of Industrial Accidents for the Commonwealth of Massachusetts, and also chair of something called the Healthcare Services Board. My responsibilities were to assist in implementing the medical aspects of the Workers' Compensation Reform Act that was signed into law in Massachusetts in 1991. And I continued at this work for about 4 years. So the experience I bring as a medical consultant to OCAL encompasses all of these activities, and I think informs the work that I do with OCAL in a way that hopefully is helpful. Mines in Northern Ontario produce a variety of metals, gold, base metals such as copper and zinc, talc, nickel, and uranium. McIntyre aluminum powder clearly is not a product of mines in Northern Ontario. However, it was for a period of time a part of mining operations and therefore an exposure that miners incurred. Occupational exposures in mining are to dust, including silica, diesel exhaust, radiation, including radon decay products, asbestos, arsenic, beryllium, and drill oil mist that contain tungsten carbide and cobalt from the tungsten carbide drill bits. The raison d'etre for OCCU, in my view anyway, is the prevention of occupational disease and just compensation of injured or ill workers. To this end, occupational consultants and staff are engaged in a variety of activities, and I thought it might be helpful just to briefly review those. These activities include reviewing medical records and occupational exposure files to examine basis for filing a workers' compensation claim or appealing a denied claim. This is an activity that we put a great deal of thought, energy, and effort into. It's a collaborative effort between physicians, occupational hygienists, and for every claim that we determine has basis and decide to submit, there are a number of claims that never get submitted because our review does not reveal sufficient basis for filing that claim. In addition to those activities, OCCU staff and consultants write review papers on selected diseases and also on selected exposures found in mining. I want to state very clearly that OCCU staff and consultants could not do our work without the help of physicians in Northern Ontario, and we thank you very much for that. Miners are at risk for a number of diseases. These include pulmonary disease, cancer, musculoskeletal disease, and increasingly, as Andrew pointed out, cardiovascular disease. The focus of my talk here today will be on pulmonary disease, specifically chronic obstructive pulmonary disease, asthma, sarcoidosis, and lung cancer. Of course, it's the case that pneumoconioses are important among occupational lung diseases and attributable to exposures in mining. Unfortunately, there's insufficient time today to go into each of these as well as the others that we have targeted. This is Dr. Bernardino Ramazzini. For those of you who don't know, Dr. Ramazzini was born in Carpi, Italy, near Bologna. He practiced medicine in Padua, Italy in the late early 1700s. And in 1713, he published a treatise entitled De Morbis Artificum, or Diseases of Workers. It's a remarkable book, and I urge any of you who have an interest to read through it. With regard to the questions Hippocrates asked his patients, Ramazzini suggested an additional question. He wrote, I may venture to add one more question. What occupation does he follow? That was not among the questions that Hippocrates asked. The occupational history is necessary to the diagnosis of an occupational disease. Information about the nature and type of exposures, about the intensity of exposures, the duration of exposures, latency, and use of respiratory protection. Temporal association is particularly important when the latency of the disease is short. For example, asthma, extremely important to making a diagnosis. Use of respiratory protection, it's important to understand whether it's the proper respiratory protection for the exposure at hand. Is respirator fit testing available and carried out? And is the respiratory protection worn by the workers? Baratovina and Bates in 1996 published a very interesting and short article in the American Journal of Industrial Medicine. Their interest was looking at compensation claims for asbestos-related diseases, compensed claims. And they examined workers' compensation claims data from British Columbia and also from New South Wales. They looked at claims that had been compensated over the period 1980 to 1994 for asbestosis, lung cancer, and mesothelioma. And the results are shown on this slide. I'll go to the totals to save a bit of time here, but 657 cases of asbestosis were compensated in these two provinces. For lung cancer, the number of cases that was compensated, asbestos-related lung cancer, was 113. Mesothelioma, 660. It's generally accepted that the ratio of asbestos-related lung cancer to mesothelioma is at least 2 to 1. Some people think a little bit higher than that. But assuming 2 to 1, the number of lung cancer cases that asbestos-related that would have been expected based on the number of mesotheliomas that were compensated would be 1,320. And instead, 113 were compensed. So the conclusion, the data show that 1,207 cases were uncompensated. 1,207 cases went missing. And so the investigators asked why. And their conclusions were that the reasons were two. One was that an occupational physician or any physician taking a history from a patient with lung cancer who also smokes stops the history taking process at smoking and never gets to work, so that exposure to asbestos is never uncovered. And the second is that there was the mistaken belief that asbestosis was a necessary precursor to the development of an asbestos-related lung cancer. So this demonstrates how important taking an occupational history is to determine the prevalence of occupational disease. Determining the true prevalence of occupational disease provides incentive for prevention and is important not only for the compensation of that individual worker. In addition to its other activities, OCAL consultants and staff have prepared review papers on selected occupational diseases and also selected exposures within the mining industry. Completed to date here in Sudbury are review papers on COPD, sarcoidosis, lung cancer. We are in the process of developing a review paper for occupational asthma. Why did we pick these diseases? We picked COPD, asthma, and lung cancer because these are common diseases. In part because they are such common diseases, their work-relatedness is often overlooked. We picked sarcoidosis because its work-relatedness is often not even considered because it is considered a disease of unknown etiology. And as I just stated, failure to recognize occupational disease results in denial of compensation and loss of incentive to prevent. Chronic obstructive pulmonary disease is the fourth leading cause of death worldwide. Population attributable fraction estimates for smoking were given in a statement by the American Thoracic Society in 2010. The range is 0.9 to 98%, less than 80% overall. The CDC in the Morbidity and Mortality Weekly Report in the fall of this year estimated that 24% of adults with COPD are never smokers. Other causes identified by the CDC were genes, chronic asthma, chronic bronchitis, secondhand smoke, and occupational exposure to vapors, gases, dust, and fumes, or VGDF. The Global Obstructive Lung Disease Initiative in its 2019 update defined COPD as a common preventable and treatable disease characterized by persistent airway symptoms, usually caused by significant exposure to noxious particles or gases. The basic mechanism, inflammation, as it is with most other chronic disease. The diagnosis of COPD depends upon the context in which you're trying to make the diagnosis. In the clinical context, it is based upon spirometry with a post-bronchodilator FEV1 to FVC less than 0.70. JAMA in August of 2019 looked at this ratio and its validity in assessing severity of COPD. And what they found was that the use of the ratio performed better than the lower limit of normal in predicting COPD hospitalization and mortality. In the epidemiologic context, the diagnosis of COPD may be and usually is different. The National Health and Nutrition Examination Survey and the National Health Interview Survey use self-reported physician diagnosis of chronic bronchitis, emphysema, or COPD to define COPD. Margot Becklake is a South African transplant to Canada. She was one of the first to recognize the association of COPD with exposure to work in dusty occupations, in dusty trades, and this was in 1985. In 1989, in a review article which she authored, she stated, "This evidence, reviewed here according to accepted criteria for establishing causality, leaves little doubt that occupational exposure to dust and or to dust and fumes may be causally implicated in the genesis of COPD." So Dr. Becklake was way ahead of her time. Since then, the Global Occupational Lung Disease Initiative in its update confirmed BGDF as a cause of COPD. The American Thoracic Society did the same thing in 2003 and 2010. OMLAND in 2014 conducted a comprehensive systematic literature review of occupational exposures and COPD and found causal associations between vapors, gases, dust, fumes, and risk for COPD. The Collegium Ramazzini, an international organization of health professionals, in 2016 published a position statement on occupational exposures and COPD. In its position statement, the Collegium Ramazzini recommended a new paradigm for consideration, and that is that we recognize and regulate mixtures of agents, not just single agents, one at a time. And I know this is an area of interest for Paul Demers in the Occupational Cancer Research Center. It applies not just to COPD, but to other disease outcomes as well. The National Health and Nutrition Examination Survey has provided an abundance of data for looking at various exposures, including occupational exposures and COPD. It's an in-home telephone interview survey, which also includes examination, which includes spirometry. NISDU et al. Used data from 1988 to 1994 to examine COPD occurrence and workplace exposures. What she found and published in 2002 was that 19% of COPD cases were attributable to workplace exposures. Interestingly, there was a 31% attributable risk among non-smokers, and this has been replicated in a couple of other studies. Kurth used NHANES data over the period 2007 to 2012 and observed a prevalence among minors of 22.66%, which was statistically significant. This was published in 2019. The prevalence odds ratio was 2.04. So at least a twofold increase in risk for COPD among minors. Kurth took this to the next step. He looked at occupational exposures in mining and extraction and found as causally associated, or found an increased odds ratio for diesel exhaust, dust, volatile organic compounds, polyaromatic hydrocarbons, and fumes and other chemicals. Mabilla et al. Looked at mine dust exposures using National Health Interview Survey data. For those miners with very high exposure to dust, he found a twofold increase in risk for chronic bronchitis, close to 8-fold increase in risk for emphysema, and a 2.5-fold increase in risk for COPD. Many miners and others with COPD have a history of smoking. So the question is it the smoking that causes the disease, or Could it be that vapors, gases, dust, and fumes also on their own cause COPD or interact with smoking to increase the risk for COPD? Trupin and Blank looked at this. Trupin did a population-based interview survey and found an odds ratio for vapors, gases, dust, and fumes of 2.4, which approached statistical significance with a confidence interval of 0.9 to 6.1. Odds ratio for smoking was 7. Odds ratio for exposure to both was 18.4. So these data indicate a greater than additive, greater than multiplicative interactive effect of smoking and occupational exposures on risk for COPD. The study by Blank et al. Found similar results and close to twofold increase for vapors, gases, dust, and fumes, 7-fold increase in risk for smoking, and with both a risk of 14.1. Lung cancer. Canadian Cancer Statistics in 2017 published data showing that lung cancer is the third leading form of cancer in men, second in women. Leading cause of lung cancer, according to Canadian Cancer Statistics, is cigarette smoking. They identified other factors as contributing and important, including secondhand smoke, COPD, and family history. Ontario miners are exposed to at least 5 lung carcinogens: silica, diesel exhaust, radon, arsenic, and asbestos. Occupational Cancer Research Center and Cancer Care Ontario published in 2017 the results of an examination of attribution of lung cancer in Ontario to silica, diesel exhaust, radon, and arsenic. They looked at attribution in the general population and also attribution among miners. And you can see from this slide that the burden among miners was significantly greater than the burden among the general population. For example, diesel exhaust, 2.1% among the general population, 40% among miners. So this is a remarkable statement about the risk for lung cancer among miners in Ontario. So work in Ontario mines is associated with increased lung cancer risk. The risk depends upon the cumulative dose, which in turn depends upon the intensity of the exposure, the adequacy of ventilation, the use of proper respiratory protection, and as Andrew was talking about earlier, pre-exposure lung overload. I think we're only beginning to understand the impact that this may have on lung burdens and risk for disease. Okay. Other important variables with regard to lung cancer are latency, presence of non-malignant lung disease. There's been some debate about whether the presence of non-malignant lung disease is reflective of higher dose, or whether these lung diseases have an independent and contributing are an independent contributing risk factor for lung cancer. Arguably, it's reflective of higher dose, but there are also studies that show an independent contribution. And of course, dose-response relationship is very important. So the dose-response relationship has been analyzed for a number of agents with regard to lung cancer outcome. For asbestos, it's been known for a long time that the dose-response relationship is linear. It's been found to be linear for radon, nonlinear for silica at higher doses, although at lower doses it appears to be linear. For diesel exhaust, the dose-response relationship remains to be determined, although data analysis indicate that there is an increased risk for lung cancer at concentrations of diesel exhaust below permissible exposure limits. COPD has been shown in some studies to be an independent risk factor for lung cancer. Silicosis has been shown in some studies to be an independent risk factor for lung cancer. Liu et al. Looked at silicosis in this regard. And what he found was that the dose of silica, the cumulative effective dose of silica, is higher, silicotics versus non-silicotics. However, when he stratified by exposure and looked at prevalence of lung cancer in silicotics, silicotics and non-silicotics at a given cumulative dose, what he found was that there really was no difference in hazards ratio for lung cancer depending on presence or absence of silicosis. In the group overall, 1.52. In the group without silicosis, 1.50. So at a given dose, it doesn't really make much difference whether you have silicosis or not with regard to risk for lung cancer. Now, we looked at smoking and vapors, gases, dust, and fumes, and COPD. So let's look at silica radon smoking and lung cancer. Is there an interactive effect? And if so, what is it? A number of studies have been done, and I'd just like to say that Paul Sampara, who works with OCCUPATIONal, has created a detailed review paper of lung cancer in minors that looks at this question and will be made available if it has not already been made available. But what has been shown is that the interactive effect between silica and smoking is greater than additive and close to multiplicative. Between radon and smoking, it's greater than additive. Silica and radon, greater than additive. I think we can skip over this. I think we've been through this. I would like to point out that uranium miners who also work in gold mines are at increased risk for lung cancer compared to uranium miners who did not work in gold mines, probably because of their exposure to arsenic. So occupational exposure to diesel exhaust increases risk for lung cancer. There's also evidence that occupational exposure to diesel exhaust increases risk for bladder cancer. IARC in 2014 stated that diesel exhaust has been shown to have a, quote, positive association with bladder cancer. A study that was published the following year and therefore was not included in IARC was a large study by Lativovic here in Canada, and what they found was that individuals who were exposed to diesel exhaust at high levels for more than 10 years had an odds ratio of developing for bladder cancer of 2.45, which was statistically significant. Minors were identified as a group with high-level exposure to diesel exhaust. So in conclusion, underground miners in Ontario are at increased risk for lung cancer, particularly miners who smoke. For this reason, low-dose chest CT scan screening for lung cancer may be appropriate for these underground miners. I've had some experience with low-dose chest CT scan screening in the past in the US, and I think it is very important to consider this because these miners are at high risk, and LDCT screening has definitely been shown to reduce mortality from lung cancer. What remains to be worked out is that many of the guidelines are based on smoking, and we need to shift this paradigm to include occupational exposures in addition to, or perhaps in some cases in place of, smoking to determine who should be screened with low-dose chest CT scans. Sarcoidosis is a disease of, has been long considered a disease of unknown etiology. It was first discovered 120 years ago. The epidemiology prevalence depends upon geography. Highest prevalence has been observed in Northern Europe. There's an increased prevalence among African Americans. Family history in about 4 to 10% of cases. Sarcoidosis is a chronic granulomatous disease, systemic granulomatous disease affecting multiple organs. Diagnosis of sarcoidosis is based upon the finding of characteristic clinical and radiologic findings, non-caseating granulomas in 2 or more organs, and exclusion of alternative diagnoses, such as chronic beryllium disease and hypersensitivity pneumonitis, both granulomatous diseases. Sarcoidosis is an immunologic T-cell mediated disorder. Interestingly, with sarcoidosis, as with hypersensitivity pneumonitis, it appears that smoking protects you from getting the disease. In the mid to late 1900s, pine tar was identified in the southern U.S. as a possible cause of sarcoidosis. In 1998, Rasmussen published an article showing an odds ratio of 13.2 for occupational and environmental exposure to diatomaceous earth containing 70% cristobalite. And of course, after the World Trade Center collapse in 2001 in New York City, a cluster of sarcoidosis was identified among first responders. And so all of these things led to a reconsideration about whether sarcoidosis is actually a disease of unknown etiology. A case control study published by Newman in 2004 found that cases were more likely than controls to report employment in dusty trades and any type of mining as an activity on the job. So to summarize, sarcoidosis has been associated causally with exposure to silica, World Trade Center dust, metal dust, chemicals, and mycobacteria and fungi. So in conclusion, to diagnose work-related sarcoidosis, first diagnose sarcoidosis, then assess occupational exposures and eliminate other possible causes. It's very important to remember with sarcoidosis and also with chronic beryllium disease that because these are immunologic disorders, the usual rules of the game do not apply with regard to latency and also with regard to dose response. It's variable because it is an immunologic disease. I'd like to quickly go through asthma if we have time. So occupational asthma is the most common cause of occupational lung disease in developed countries. It often goes unrecognized. Work-related asthma should be suspected in every new case of adult onset asthma. Occupational asthma comes in at least 2 different forms. New onset asthma, which is usually referred to as occupational asthma, and work exacerbated asthma. Occupational asthma can be caused either by a sensitizer or by an irritant. Work-related asthma is almost always caused by an irritant. Laura Chan Young, who is a heroine of Canada, in my opinion, published a classic article in 1995 in the New England Journal of Medicine, and she divided occupational asthma into 2 more categories. One is occupational asthma with latency and occupational asthma without latency. Occupational asthma with latency is caused by sensitizer, low molecular weight such as diisocyanates, high molecular weight such as shellfish. Occupational asthma without latency is almost always caused by irritants, is an irritant-induced disease. So to diagnose occupational asthma, you first have to diagnose asthma, then identify exposures. Temporal associations between exposures and symptoms is critically important. It requires a detailed, time-consuming occupational history. Peak flow diaries and pre and post shift spirometry and or methacholine challenge testing can be very helpful. To conclude, Ontario miners are at increased risk for non-malignant pulmonary disease. Ontario miners are at increased risk for lung cancer. Smoking adds to the risk for COPD and lung cancer in a synergistic manner, synergistic with the occupational exposure. Just one more thought, and that is that because of the increase in risk for lung cancer, I'd just like to reiterate consideration for low-dose chest CT scan screening for lung cancer among minors in Ontario is something that probably should be considered seriously. And I thank you very much for your time. And Andrew and I are here to answer any questions that you may have. Thank you.
So I'm just going to pull up the chat section here, and if we have anybody would like to type in a question there, we can try to answer the questions. I hope I'm in the right area to see the chats. See. Are people able to enter messages that we can see? I'm not seeing any come up. Yes, okay, great. Who are the presenters again? So someone's asking who are the presenters again. So we had Dave Wilkin, who is the Chief Operating Officer for OCAL. Myself, Andrew Zarnke, who is an occupational coordinator for the McIntyre Powder project, as well as GE and Ventura groups. I'm also working as a graduate student at Laurentian University with Doug Borum. And then we had Dr. Christine Oliver. Well, again, I'd just like, why is McIntyre powder invented and by whom? What was the rationale? So it was developed in the McIntyre Porcupine mine up in Timmins. It was developed by a research organization called the McIntyre Research Foundation that was developed in response to the increased prevalence of silicosis found in the mines at the time. There was a number of people a part of that organization, and this was all done in the early or late 30s. And there was, a limited amount of research that was conducted at the time to prove its validity. There was a lot of not a lot of information known about the development of silicosis either at the time. But that was who developed it, and their rationale was initially they saw that aluminum in solution decreased the solubility of silica particulate. So they thought that this aluminum would kind of surround silica particulate in the lung and kind of prevent macrophages from engulfing them and incorporating them into the tissue, causing this fibrosis action, which was later shown in, there was a study by Sandra Rafat and also Susan Peters out in Western Australia that both showed that there was no decrease in the prevalence of silicosis in McIntyre exposed miners. So someone asked, when did the use of the powder stop? So it was in 1979 when they stopped using it. Between McIntyre powder and neurodegenerative. What do we know currently about the relationship between McIntyre powder and neurodegenerative diseases? So there hasn't been any studies directly. Maybe Dave, do you want to answer some of these too? I don't know if there's other people here that want to help answer some of them, but here's Dave Wilkin.
Hi, one of the papers on our website that we'll be sending out a link to is a review that OCAL commissioned from Dr. T. Guadati, who's a occupational health physician and editor of a major occupational medicine journal in the U.S., to review the available studies on McIntyre powder and neurological conditions. Really, to this point, the only epidemiological studies on that question are published are the Rifat and Peters papers that Andrew mentioned, one from Ontario, one from Australia. And Dr. Guidati also brought in some biostatisticians to assist him, and has concluded that the findings of both of those papers of increased risks of neurological conditions are the best information that we have right now, and that those findings hold up. I mean, at this point, there's not a lot known, though. For example, about how it would contribute to particular conditions, or what conditions those would be. The Occupational Cancer Research Center is currently conducting a health records matching study on McIntyre exposed minors, other minors, and then comparing both of those groups to the general public with respect to neurological conditions. And that study is due to be released early in the new year. So hopefully we will have some more information about that quite soon. Is the WSIB paying out claims based on McIntyre exposure? With respect to the McIntyre powder itself, as far as we know to this point, the main effect in workers' compensation claims is that the board has begun including McIntyre powder exposure in its calculation of occupational dust exposure that it uses to make decisions on COPD claims. Although that is a straight up calculation and doesn't take account of the lung overload issues that Andrew mentioned in terms of the intensity of the exposure and the fact that it occurred before people went down into the mine.
There's a question here about low-dose chest CT scan screening for lung cancer. And the statement says, I noted your reference to LDCT screening, which is recommended in several guidelines, including NCA lung cancer screening guidelines. And so the question to me is, what has my experience with this been in the US versus Ontario? Most of my experience has been in the US. I've not gotten involved here in Ontario yet, although I'm happy to do so. But in the US, the way in which the guidelines were originally set up based on cigarette smoking as the only criteria to be used for determining eligibility. Subsequent to the NIH randomized controlled trial, the American Association of Thoracic Surgeons and the National Comprehensive Care Network developed different criteria. They developed a second tier of criteria, which eliminated the abstinence criteria. That is, you had to have continued smoking for up to 15 years to be eligible. And so the American Association of Thoracic Surgeons and the National Comprehensive Care Network said the abstinence criteria are not necessary. There are a lot of problems with using abstinence criteria. In addition, they reduced the age of eligibility in those who had an occupational history of exposure to a lung carcinogen from 50 years. There was a reduction in age. I can't remember exactly what, I think from 55 to 50 years. And then with regard to number of pack years of smoking, they reduced it from 30 to 20. So this reduction allowed some flexibility in terms of who would be eligible for low-dose chest CT scan screening. Why this was important was because of insurance coverage. But since then, there are groups working for the Department of Energy and working in Libby, Montana, where Libby, Montana was like asbestos in Quebec. High prevalence of lung cancer and malignant mesothelioma and other related diseases in Libby, and Department of Energy workers were at high risk for lung cancer. And so there are groups within Libby, Montana, and also groups in the Northeast working with the Department of Energy who have mobile vans that are standardized and able to take low-dose chest CT scans that meet criteria from the American College of Radiology. And so they have gone out and done LDCT screening on a population basis of workers, and in the case of Libby, Montana, residents who are at increased risk for lung cancer. So that is a model, I think. Further work needs to be done to transition from cigarettes as the only acceptable criterion screening to occupational exposures as an additional or perhaps their own acceptable criterion for screening. But there is precedent in the United States. I don't know if that answers your question or not.
See a question about PM 2.5 and what may be an effective control. Oh, Kevin's going to answer a question, part of that. That'd be good. Installing diesel particulate filters. So yeah, so one of the exposures related to PM 2.5 and one of a major part of diesel exhaust is the fine ultrafine particulates. So Kevin's suggesting that, you know, and these are things that are being implemented, I think now, retrofitting diesel engines with particulate filters. And then I was also just thinking broader in terms of, you know, the awareness is there and the literature is there to support the effects from PM 2.5. So incorporating monitoring for PM 2.5 so that that can help inform control measures in any kind of situation, whether it be environmental or in the workplace. Yeah. Yeah, electric mining equipment. Okay. Thank you very much for everybody for staying on and asking questions. What we have. We'll be at the end of our, okay. So we've been recording the presentation so we can make that available. We can email out to all the registrants at a later date to let them know how you can access that. We'll also be sending out PDFs of the slides and also a survey. We'd love to get, one of the main goals of this circuit of presentations was to really focus on physicians. So we'd love to get people's feedback on, one, the number of people that were present with you while you were listening to the talk, as well as what your occupations were and what your interests in the talk were. So we'd greatly appreciate that. So thank you very much, and thanks again.